So for those of you who have been here before, this is going to look really familiar, but we just wanted to kind of remind everybody that this seminar series, actually you can go to the next slide, is actually part of a larger effort. We have this program where we are hoping to advance the science on recovery community centers and how that can support persons treated with medications for opioid use disorders and other folks in recovery. And our goal in this project, which is a really unusual and great project and that the NIH has made possible, is to really engage multiple stakeholders from multiple perspectives about how that science needs to be built, the questions that need to be asked, and how they ideally should be answered. And this is, the seminar that you are here for now. This is a great way for us to connect with you all and to really advance our thoughts and thinking together on this. What we are doing then behind the scenes and hoping to share with you all is the tools and products that come out of our working together in the seminar series and in other ways. And if you can go to the next slide, I think we don't talk about those yet, but I'll get there in a moment. This is our steering committee, our diverse group of scientists, clinicians, RCC leadership, and persons with lived experience from multiple organizations across the US. And you will see here Sarah Wakeman in the second row on the right. She's going to be our fabulous moderator for today's discussion. And we really do hope it's a discussion. We hope that as you guys have a thought or a comment that you'll jump in and ask it. And of course, we have questions for the panelists as well, but we definitely want you to be included in the discussion. And if you go to the next slide, I can show you about some of the products that we have underway. So as you all know, we do record all of our seminars. So afterwards, you can just go to our website, get the video recording, you can get the slides. And sometimes when you guys ask for things, additional materials, we then pull them together, and sometimes we already assemble them ahead of time and put them there. So the website will also then link any of these kinds of additional materials that might be helpful or interesting to you guys. So that's there. We will be funding folks to go to scientific conferences to just kind of spread the word about recovery community centers, because believe it or not, within science, not a lot of people know about them. They really need to. So when those conference presentations happen, we'll also put those slides on our websites and share them with you all. A thing that's going to be underway is the funding for pilot studies. For those of you who want to do studies together with RCCs, we have funding opportunities available for that on our website. And that's underway as well. And then we also will be collecting some scales and other things that might be useful to you. If you go to the next slide. We have currently postdoctoral position open, which we're very excited about. If you're interested in doing a postdoc with us, and particular on recovery support services, contact us, go to the website and read about it. Next slide. And this is just what I want to mention. This is what the website looks like. So you can see here's an example for the funding for pilot studies. We have all of this kind of stuff here, so you can click through the seminar series, the hands-on support, linkages, and that kind of stuff to get you oriented. And as always, feel free to just reach out to us with an email and ask a question or tell us about something we should know. For example, we have this new thing here. Where do we have it? Recovery happenings. Actually, don't see it on the screenshot, but it's on the website. If there's something cool happening in your world that you want people to know about, let us know. We'll share it here. All right, and I think that's it. Is there another slide? Same thing here for funding. We do have a call open. So that's where we are at. So go to our website to get all the additional information for the other programs and activities we have. All right, then I'm almost ready to turn this over to Dr. Kelly to get us going. But I mentioned that we have multiple stakeholders and we all come from different perspectives. And we just always like to ask at the very beginning of who you are. And if you can start that poll now, this is really for us to figure out, who's listening and which perspectives we're actually hearing in our meetings. So if you could click through them, that'd be wonderful. And you do need to scroll down. There's like a little tab on the side. So scroll down. There should be a total of 4 questions here for you. And Loretta, we were actually just talking about step rocks right before we got started here. Great to have you here. And then once you're done answering the questions, there should be a blue submit button at the bottom. All right, Hazel, what's it looking like?
We have 68% now, so I'll give it like 30 more seconds and then.
All right, but we're closing that out. John, do you want to go ahead with introducing Sarah, or do you want us to be done first with the poll here?
Do we post the results on here? I can't remember.
Sometimes we do. We don't have to. For
Yeah.
the next one that Sarah's going to ask, which is more topical,
Okay.
we usually do, but it's up to you.
All right. Well, we can. I think we can go ahead. And thanks, Bettina. Welcome, everybody. Good to see you. Thanks for coming. We've got, I think, a very exciting panel. I'm super excited to have this discussion today. And our celebrity moderator today is Dr. Sarah Wakeman, who is on our, I'm very happy to say, on our advisory board for the grant, this R24 grant, which is supporting this initiative. And thank you, Sarah, for that. Now, just as a formal introduction, Dr. Wakeman, Sarah Wakeman, is the medical director for the Massachusetts General Hospital Substance Use Disorder Initiative, the program director of the Massachusetts General Hospital Addiction Medicine Fellowship, and medical director for the substance use disorder at Mass General Brigham, and an associate professor of medicine at Harvard Medical School. And let me just say, if you don't mind, Sarah, she's a wonderful colleague and a world champion, I think, a world champion at reducing and helping fighting the fight to reduce stigma and discrimination and promoting harm reduction and treatment and recovery for people suffering from substance use and substance use disorders. So thank you, Sarah, for all the work that you do, and I'll hand it over to you.
Thank you, John, so much for those kind words and for always being a wonderful colleague and collaborator along the way. I'm really excited to be here today. So good afternoon. Thank you all in the virtual audience too for joining us. And I want to start by thanking especially my amazing group of panelists and colleagues who are here today to share their wide range of expertise and perspectives on bridging the gap between healthcare systems and recovery community centers. I'm going to start by introducing myself a little bit more, providing a brief overview of the work we've collectively done at Mass General, and then briefly introducing my colleagues. We'll pause for a quick poll from folks in the audience, and then we're going to hear from each of the panelists about their unique perspectives and open it up for discussion with you in the audience. And we hope that this is a lively and back and forth discussion. As Dr. Kelly mentioned, I'm an addiction medicine physician by way of internal medicine, which means I both provide treatment for substance use disorders, but also general primary care in one of our community health centers and hospital-based medical care. My passion and interests are in how we integrate effective substance use services into general medical settings like hospitals and primary care, the emergency department, and other settings. And I've been really fortunate to spend the last 7 years working with my co-panelists on implementing just that at Mass General Hospital. Our substance use disorder initiative has really been an effort to try to bring care to where patients are showing up when they come into healthcare settings and where they're receiving the rest of their medical care. And a core and utterly invaluable component of this work has been the involvement of peers that we call recovery coaches here at MGH, and obviously many others do too. We now have 25 recovery coaches across the Mass General Brigham system, and at MGH we have 14 recovery coaches. We often refer to them as the human glue that holds this whole model together, and we've learned and continue to learn so much from all of them, and from leaders like Wendia Rodriguez, who you'll hear from today, who's our program manager for the recovery coaching program. Some of the greatest challenges we face in supporting our patients are the tremendous gaps that exist in meeting the range of needs that they struggle with. We can offer great addiction treatment in the clinical setting. However, for patients who are unhoused, dealing with the burden of the criminal legal system because of the United States racist war on drugs, struggling to find employment, or simply dealing with the burden, isolation, and trauma of living through the discrimination our society still inflicts on people who use certain substances. In those contexts, our clinical tools often feel hugely inadequate. So it's incredibly exciting to be here today with all of you to try to think about how to build stronger partnerships between the healthcare setting and recovery community centers, and how RCCs might provide another crucial layer of support, connection, and resource for patients we're seeing. While some of our panelists like Wendia have a deep knowledge of RCCs, many of us live in the medical world and have limited, if any, experience with RCCs. One of our goals today is to really share the perspective of providers in the healthcare space, and then hopefully to discuss with you in the audience, many of whom are also experts about RCCs, and to start thinking about building stronger bridges between our worlds. So with that preface, I'd like to introduce my co-panelists today. Dr. Jean Lambert. First we're gonna do did you want to do the poll first? Let's see.
Yeah, you can do it now, you can do it after the intros.
Sure, it looks like there's a poll. So why don't we pause for that? And do we, yep, there we go. So they're popped up so you guys can see those questions. The first is, do you think it would be helpful if healthcare systems told their patients about recovery community centers? And then the second is a list of barriers that interfere with healthcare systems linking patients with substance use disorder with RCCs. And I'll defer to Hazel and Bettina on when we want to end the poll. So you guys just let us know.
We have 76% voted now, so I can end the poll now. And would you like me to share the results?
Please do.
Okay.
Great. So pretty strong agreement that this would be helpful, which is wonderful. And then really helpful to see the range of barriers. Okay, great. Do you want to go to the next? Great. So with that, I'm going to introduce our panelists. So I want to start by introducing Christopher Shaw. Christopher Shaw is a nurse practitioner. He's an expert in addiction care, and he's the nursing director of our inpatient addiction consult team and our nursing leader across the substance use disorder initiative. Next. Dr. Jean Lambert is an addiction medicine physician and also a long-term hospitalist at Mass General Hospital. He's also the associate medical director and director of clinical operations for our inpatient addiction consult team. Dr. Marty Kane is a clinical psychologist and the clinical director and my long-term partner in crime in all of this, leading efforts to establish and implement the substance use disorder initiative. Next, Wendia Rodriguez is a certified recovery coach. She's the program manager of the MJ's recovery coaching program. Next. And lastly, Dr. Davida Schiff is a pediatrician and addiction physician, and she's the medical director of our Hope Clinic, which is the clinic for pregnant and parenting people and families who are affected by substance use disorder. Great. So I'm going to launch into questions now. And as we said, feel free to jump in if you in the audience have a question or discussion point you want to raise, or to save it and bring it up at the end, whatever works better for people. So Christopher, I'd like to start with you. As a nursing leader in this space, you've been a role model for thinking about and caring for our patients in a holistic and person-centered approach. What are some of the challenges you see our patients struggle with in the transition from the inpatient healthcare setting into the community?
Thank you, Sarah. I appreciate this question as well. What I really see is some of the major challenges are when a person is here in the hospital on an addiction consult team, and we're welcoming a patient into a space where they're provided care, they're walking towards health, they're supported, hopefully, and they're given a safe place. For a lot of our patients, they're leaving the healthcare setting, an inpatient setting, going out into the community. And what is community? Community is a place where a person feels safe and where they're cared for. However, our patients may not have housing, may not have a job, may not have a place to even properly store their medications, and don't have that safety net to provide them with the ongoing care and transition that they need. So I think that that's one of the major struggles. The other is when you're in a setting that's supported in where you are getting care, it's much easier to follow a prescriptive kind of pattern for health, taking medication, taking care of wounds, things like that. And then when you're out in the community, if you're lucky enough to have a community, then things become a little bit more challenging. So I think the struggle for a lot of patients is not having that connection that they maybe have when they're in an inpatient setting and getting out into the community. Who do they connect with, and who is the person? Oftentimes I will ask a patient, who has your back? Who's got your back out there? And many patients will say, I don't have anybody. So really making that connection with healthcare, with a community in general, with a recovery community, if that's what they're looking for. Those are some of the major challenges that I see.
That's perfect. Thank you so much, Christopher. I think those themes are so true, and I think Dr. Lambert will probably pick up on those. So Dr. Lambert, turning to you next, you also live in the inpatient space and have seen many of these same challenges that Christopher just really eloquently described. Although RCCs exist across Massachusetts, they're often not talked about or even known about in medical settings. What do you think are some of the reasons for this gap, and what barriers exist to forming more robust connections from the perspective of a healthcare provider?
Thank you, Sarah. I really appreciate the opportunity to be here, not only to kind of address your questions specifically, but also to kind of learn more about RCCs. In terms of a little bit of background, I would tell you my clinical practice in addiction medicine is wholly hospital-based, where most of the patients I see are high acuity, high complexity, with accompanying surgical, medical, or psychiatric emergencies. And most of the times our primary focus is medical surgical stabilization, along with management of acute intoxication withdrawal states, and in many cases, initiation and or adjustment of pharmacotherapy for accompanying severe substance use disorders. I will say my historical understanding and teachings of the substance use care industry and the continuum of recommended care is based on the ASAM levels of care with the corresponding National Survey of Substance Abuse Treatment Services, NSAT, 6 treatment domains, which span the care continuum of substance use care from outpatient to my primary domain, which is the hospital setting. So I would say before this, the opportunity to talk today, my understanding of other aspects of this continuum, including RCCs, was on a cursory basis. When you talk about my understanding of the gaps as I see them now, I would say number one, the major reason is likely a lack of awareness of what RCCs or recovery community organizations are and where they exist and what their roles and functions are in the care continuum of patients with substance use disorders. And I can speak from my personal siloed experience in addiction medicine. I'm wholly unaware of RCCs and their existence, not only locally, but nationally, what that model looks like. Currently, when I talk to patients about treatment options after medical stabilizations, initiations of pharmacotherapy, starting to engage in kind of initial abstinence or recovery talk, I would tell you RCCs aren't part of any treatment paradigm that I'm able to discuss with the patient, or are they part of any of the nationally devised care continuums for substance use care treatment and delivery. And in this context, RCCs will not be a part of any dialogue regarding treatment options after medical stabilization that I would have with a patient. A second gap, I think, is what is the RCC model of treatment and recovery? Are interventions or pathways standardized and validated? Is there a universal, standardized, validated model of intervention specific to RCCs? Is there state or national quality oversight and management? I mean, these are all questions that I don't know the answer to because of my newfound understanding of RCCs. A third potential gap is medical provider community education. Specifically, I would assume individuals in the medical provider community, and maybe in the substance use care provider community, don't understand specifically what are RCCs, what's the actual model, what's the design of community integration, and how that looks and works for a patient. A fourth gap I would think about is if I was aware of RCC and understood its benefits in terms of what it could offer to a patient in early recovery or along their recovery journey, how would I link a willing and interested patient with an RCC? That's an unknown to me. But I would say my philosophy is based on a patient-centered, informed, engaged, and holistic approach, individualized to that patient's treatment needs. And so in that context, I wonder if there's a subset of patients with substance use disorders that would benefit more from engagement with an RCC. Again, these are unknown questions for me that represent gaps in my treatment knowledge. In terms of barriers, or more specifically, I like to envision these as opportunities. I guess I would think where along the current national levels of care continuum for patients with substance use disorders would the RCC lie? And what are the current clinical care models which don't include RCCs or may have one or more components of an RCC model? And how do the current clinical models adapt or integrate RCCs into their clinical pathways? And I guess from kind of a medical provider perspective, there's certain questions I would think that would need the answer before we talk about adoption or some partial adoption of RCCs in our current treatment paradigm. And these questions are most likely related to efficacy, comparative effectiveness, safety, cost, long-term outcomes, whether it's complementary aspects to RCCs to existing substance use care models of care, and more importantly, how and what would be the process for substance use providers to establish relationships with RCCs in the community? How will we utilize all the available treatment modalities to serve our patients in the most effective, highest quality, and most patient-centered approach going forward? So those are some of the things that I'm challenging myself to learn more about, and I'm grateful to be a part of this discussion and learn more going forward.
Thank you, Dr. Lambert. I have to say, it's not usual that we, type A folks on the medical side are asked to speak about something that we know very little about. So I know I felt that tension even preparing for this panel, and I really appreciate the honesty and comfort of my colleagues in sharing what we don't know as much as what we do know. So with that, I want to turn next to Dr. Kane. So Dr. Kane, as a mental health clinician as well as an addiction expert, you offer a slightly different and crucial perspective on substance use disorder care. We often talk about Dr. Kane holding up sort of the mental health and the behavioral health tent pole in the work that we do. And the importance of peers and community-based supports has been a prominent aspect of mental health care for many years. What lessons can we learn about synergistically connecting peer and community-based supports with the healthcare setting for people with addiction?
Sure, thank you, Sarah. I will simply echo my other panelists in appreciating that we are able to have this conversation today, thinking about how, excuse me, how peers can be used to support and inform mental health care, and what mental health clinicians can learn from peer-based care has been something I've been focused on for several years now, as we've sort of built our continuum and our group of peers supporting our work. I think the opportunities are significant. We know from mental health care, peers have a fairly long history there of being involved in supporting care, in helping patients access care, in helping with a number of activities. We also know that peers have a very long history in the substance use care world, beginning probably for more than 100 years. However, how that's linked into the mental health care that can be helpful for people with substance use disorder is part of the more interesting and more recent question and concern. I think that we know that peers are often very helpful to folks, particularly around psychosocial issues, on helping people find stability, helping people access resources, helping people feel hope, helping people feel connection to someone, helping people recognize role models, and that kind of work. I think that, there is some data to suggest that these are effective interventions that people do benefit, people with substance use struggles do benefit from. There's less information to suggest that people with peers are able to impact what are more purely clinical needs, symptomatic needs. And so I think therein lies our opportunity for really synergy and creating a broader bandwidth to support folks as they're coming into recovery. Certainly not everybody who's coming into recovery has mental health disorder. Many people don't. When we do, it often really needs sort of multiple hands on deck. And so you could imagine, and certainly I read a recent analysis that offered these ideas, that certainly people with who are in recovery themselves are often very helpful to folks engaging in mental health care, getting the linkage, supporting any sort of those barriers, helping people get through that, helping people really feel supported through any anxiety they might have, acting as role models or sort of expressing themselves, helping people think about that connection. I apologize, I have dogs. Sounds like they're gonna go off. I'd say right up front, I'm sorry about that. Certainly, we know that people in recovery often are really able to help patients who are in mental health care figure out how to apply what they're learning in mental health in their mental health sessions, and what that work to their day-to-day existence. Peers can support much more in the day-to-day world than a clinician can. So another opportunity for two hands to really help. There are some challenges, I think. This is not a field that this is not an area of collaboration that has a ton of work yet done. Tends to still be siloed. Recovery people in the recovery world and people in the mental health world aren't necessarily communicating a lot yet. There are some issues. There are things like, how do we even set this up? How do we communicate to each other, and being careful in our communications around who does what. And that becomes important because roles are difficult to define. Who's the therapist? Who's the support person? Who's the counselor? What does each person do in those roles? How do we not cross over or kind of step on each other's toes? How do we sort of navigate that world? And there's an awful lot of work going on currently about role definition and peer recovery roles, both mental health and substance use. Who does what and how do they do it best? In addition to that, I think as far as mental health itself, we know that, sounds like we're gonna have a chorus here. We know that mental health services themselves are very hard to access. There are insufficient resources, I think, across the country. It's certainly at a crisis point here in Massachusetts. People have a terrible time accessing services, people with substance use disorder and people without, and it becomes extremely difficult. And so I think that's certainly an area for where peers can potentially be helpful. It's also difficult to define who needs mental health and who needs peer recovery support. So if mental health works best on clinical symptoms, an anxiety disorder or a depressive disorder or a psychotic disorder, that's pretty clear. But when someone is suffering the anxiety related to the natural stresses of being homeless, of being having an active substance problem, of being economically, being hungry, these are maybe not mental health disorders, but they have a mental health piece to them. And so who takes care of that, where the peer may be best able to actually address some of that sort of, how do we decide that? Who decides that? How does that interaction occur? And then I think the last thing I would say about this is that many people with substance use disorder have had very difficult experiences in the mental health care world. They're often, over the last few decades, we have often kind of blamed people with substance use disorder. We have decided we know best, meaning mental health clinicians know best what their recovery should look like. We have not always recognized that recovery is person-centered, person-determined. And so we've kind of made up our minds ahead of time that you need this. And if you're not willing to do that, well, then you need to go out or go away and come back when you are ready. And I think that has really left a great deal of many people with substance use issues feeling isolated, feeling alienated, feeling rejected from mental health care. And we have to know that's a piece of likely experience that we're dealing with. And so I think sometimes we can look and think about how our patients may be able to benefit more from peer-based care or from a linkage of peer care with mental health care, so that we're able to help really develop people, help people develop into what they really want to be and get their recoveries going. So I think with that, I will be still and see what else people have to offer, and hopefully we'll have a chance to come back and really think through how mental health and peer-based services can link more effectively for people over the course of recovery.
Thank you, Dr. King. You probably didn't see the chat, but people are loving fur babies, so they were very appreciating the chorus.
Yeah, I got a few, sorry.
Wonderful. Next, we're going to turn to Wendia. Wendia, as a woman and a mother in long-term recovery and a certified recovery coach, you're the expert on this panel about RCCs, and you have yourself worked in both the healthcare space and in the community-based recovery support world. What do you see from your perspective as the current barriers between building stronger linkages, and how can we on either side do better to establish these connections?
Hi, everyone. I hope everyone can hear me well. I just want to, before I answer the question, just briefly give a little history. That before we started this, I was giving a history that I worked at a peer recovery center in Roxbury. Shout out to Step Rocks. And that's where I got my start. I think I applied. I had about a year into my recovery. I was at the time jobless. So I was going for the meetings that were there. And somebody said, hey, there's a job here. And I said, I've never done this. They said, you don't need any experience. You just need to be a person in recovery. I said, okay, that's me. So I applied, and it was really interesting because the people who interviewed me were the members. So it wasn't just staff, it was the members. And then I learned that peer recovery centers were, the participatory process. So it wasn't just run by staff members. It was run by the people who were there, who were the members, the volunteers. I was the volunteer coordinator. And, I will say there was challenges, of course, but it kept me in recovery. It wasn't just a job. It was also a safe place for me to go. It was a place for me to build friendships. I'm still friends with a lot of people there. So, it helped me develop confidence in who I was and who I was becoming. Without that job, I couldn't have gotten the next job and the next job and the next job. So I always say that Step Rocks is my foundation. It was really a place that truly helped me become where I am today. And so I think one of the barriers is that, and Dr. Lambert spoke on it, and, I don't think we know enough about them. In the medical world, as recovery coaches, we will tell people, hey, why don't you go to a recovery center or meet me at a recovery center? But then I think sometimes we don't say to the clinicians, we'll say, oh, we took this person to the recovery center, but we don't really say like what that recovery center is doing. I don't think we give enough credit to recovery centers. Recovery centers are, I would say, the backbone. That is where I think some of that missing gap is after treatment, after somebody gets out of recovery, out of treatment, let's say, and they have no place to go, they can go to a recovery center. They can be safe. They can start to build community. One of the coaches I met with today, she said, the connection is the antidote to addiction. And so, that's recovery centers. Recovery centers give you that connection. And so I'm excited, just thinking on this panel right now, because I have an opportunity as a program manager now to say, hey, how can I start to connect, the coaches and really bring these recovery center and the principles in recovery centers to this medical model? And I think one of the things is having flyers of the recovery centers, having their calendars. They all have calendars of what their events are, when their meetings are, and not just 12-step meetings. They have smart recovery meetings. They have all recovery meetings. They have so many different types of meetings, different types of pathways, that when people who are on, medication assisted recovery, they can go to these meetings and feel comfortable and not feel like, well, I have to be completely abstinent or think that, I won't be welcomed. So I think one of the barriers is that we need to advertise it more. We need to, as coaches, and I still think of myself as a coach and a peer. I don't think that's ever going to go away. And I think one of the things we need to do is really push these recovery centers. I know Julia's on the line. I think we have nearly 30 now recovery centers. A few of us are planning to go to a new one that's opening in East Boston next week. One of the coaches said, hey, let's go together. So I think we need to really push these. And the other pieces, I think, and Sarah, thank you for sending that, connecting clinical people to the recovery centers. So either the volunteers can go to the medical facilities and give presentations, or providers can start going to these, recovery centers. They're all over Massachusetts. They're beautiful places, they're relaxed places. Some of them I know in Quincy have a meditation room. They have a little library area. All of them have computers. They're just wonderful places. I give a lot of my credit to recovery centers. So I really think we need to try to marry the worlds in a sense, and really bring that to the forefront. And the other piece I was thinking of when I was at Step Rocks, one of the most successful things that they used to do was I think it was MAC, which is I forget what it stands for, but it's AIDS. They do work around AIDS, and they would come and do testing. So that was a way that a clinical model would come to the center and give people free STI testings. They would give out, I think, maybe like $5 Walgreens cards or something, but it was really a way for people to get some of the testing that they needed, because instead of going to a clinic, the clinic came to them. So they had a van parked right outside of the center, and it really worked. I mean, I remember the center would be packed that day. It would be packed, people coming in and out all day to get testing. So, hi, Caitlin. So I'm really appreciative of recovery centers and what it's done in my life. So I would love for, us to as in the clinical world to really push that for our participants and patients.
Thank you, Wendia. That was beautifully said. And what Wendia was mentioning also is we're trying to think about how we could get our fellows who are doctors in training, becoming addiction specialists, to have sort of a built out part of their exposure is actually going to RCCs. So for Massachusetts RCC colleagues who are here, would love to connect with you and think about how we can do that in the future. So with our final panelist, I'm going to turn to Dr. Schiff, and then we'll open it up for discussion after that. So Dr. Schiff, thinking about the needs of parent-infant dyads is a body of work that seems like it would benefit tremendously from sort of a strengthened fabric of community-based supports. What are the areas that you've seen as the greatest needs for these young families?
Yeah, thanks so much. And I will be brief so that we can get some of the really wonderful comments that have already come through the chat. If I could really sum it up into one statement, it's thinking about how we're able to support and not surveil young families. So we, and many of you may remember in your experience as being young, exhausted parents with a newborn at home who's not sleeping, that sleep deprivation on its own can cause people to not be their best selves. But what we expect and ask of young parents who are in early recovery to meet the sort of many requirements around potentially child welfare engagement, multiple medical appointments for themselves and their baby is really tasks that I think not all of us would be able to accomplish, particularly thinking about doing it all alone. I think the unique challenges and stigma that parents who use substances experience is really worth noting. And as you think about how your recovery community and your recovery center can really support parents in this moment, we have to think about the data that we have that shows that parents who have substance use disorder are more likely to report that stigma is a barrier to them engaging in treatment than people who are not parents. And I think that just sort of data from the National Survey of Drug Use and Health that came out recently that really highlights the work that we have to overcome. I do think that a recovery community can sort of help to bridge that gap and support young families and parents, thinking about things as simple as offering a respite when women need a break and they need to bring their children in. So are there sort of family-friendly recovery centers that could offer those childcare services where someone can just say in a not shaming way that I need a break and I need someone to hold my baby. What we see actually, one of the biggest barriers in those first 3 months to people feeling like they can ask for help and support is not feeling like they know who they can turn to, that they can trust in those moments, that they know that they're exhausted and they're asking for help, but have very little around them. And I think, the fear of child welfare involvement and responses is really the biggest barrier to people engaging in care. So how can your and our community-based and medical-based services sort of work together with families to support them in their needs? And I'll stop there.
Thank you, Dr. Schiff. Perfectly stated. And I think, all of these comments are a great launching point for discussion. So I'd love to open it up to the audience. Yeah, great. I was going to say, we stop sharing them. We can sort of pretend we're in a room together and see each other's faces. And I'm sure folks have lots of thoughts and questions after hearing from all the panelists and would love to open it up to you. I know there's a couple questions in the chat that I think Hazel and others can help us get to, and feel free to just jump in.
I have a question, if you don't mind.
Sure.
So I kind of just want to pose this to everyone. So in an ideal world, what would linking patients to RCCs look like? Because we talked about, I know Wendia talked a little bit about bringing the clinic to the RCC. How do we get the patient to the RCC? And in particular, patients who might be on medication treatment for opioid use disorder, for example, patients who might be at more serious risk. What would that look like? Who would do the introduction and the linkage? And
well, recovery centers are, walk-in places. So, essentially the person can just walk in. But it can be intimidating to do that when you're in early recovery. If you have recovery coaches, that is the ideal way. Recovery coaches can meet people at the recovery center and start to make introductions that way. It's great if recovery coaches already have, people that they know there so they can introduce the person. But essentially, I think it's going to take somebody sometimes bringing them to the center. And so it would be helpful when, like I said before, if we start to do this, if clinicians can visit and see the recovery center and see, wow, this is a great place. I mean, the recovery center, I think in Marlboro has like a full kitchen, then they're cooking and doing all this stuff. So when people see that, that it's welcoming, and you can say to your patients, this is a really welcoming place, you can go to. I visited there, and you just walk in.
Yeah, I think that warm link, Wendia, is so important, and we're blessed to have recovery coaches as sort of non-clinical members of our team. I wonder, just food for thought in this weird COVID world where we've all learned to do so much by Zoom and FaceTime and other platforms, if there's an opportunity to do almost a warm handoff, if providers knew who to reach out to in an RCC, that a patient while they're in the hospital bed could actually see who the face on the other end of the line is and who they'd be going to meet, and how to actually form that connection so that walking in wouldn't feel so intimidating, particularly after a vulnerable hospitalization.
I would say, and Sarah knows this very well, I've spent the majority of my clinical career in the hospital, but I have an urging to actually bridge or connect with the ambulatory outpatient setting. And when I first learned about this discussion about RCCs, I felt that was a natural extension of how I want to practice in terms of individuals with substance use disorders. So I'm more than open to learning more about RCCs and how we can develop a model that allows us to identify patients who would best fit with RCC, and how we can create workflows and pathways so that transfer, that linkage can be established. This, I think, is a fantastic model of care that, given kind of its infancy, has the potential to be so much more in terms of the care we provide for our patients. And so I'm excited about where you are in terms of your development, and I'm open to engage in any kind of dialogue about how I, as a clinician, can be helpful. It would allow me not only to engage with patients in the hospital setting, but also follow them longitudinally and continue that connection that I make with them on the inpatient side, which I will, be open about, is a tremendous, gap in what I can provide for patients. So the opportunity to explore that, develop that continuity, I'm more in favor of. I would love to participate in any dialogue about how we can do that.
I also think, Smarty, I also think that, part of this is about the culture we create in our healthcare setting. So if we create a culture of recovery, we create a culture where we talk about it, we talk about resources, we show pictures, we get online, we make linkage through Zoom, whatever we do, and everybody who touches the patient does something like that, talks about recovery from that perspective, that it sort of starts to become, it's not a thing you go do, it's a piece of your getting well. It becomes a part of your health and wellness. And I feel like I'm thinking we've got people from all across the country who may or may not have access to recovery coaches. So what do you do if you don't? Or what if you're sort of primarily a clinician in a setting and you've got, don't have resources? It just struck me that your primary care doctor could talk about it, your therapist could talk about it, everybody who in that healthcare setting, if they're sort of living a truth about recovery as a broad-based thing, it may help you start to feel like it's not such a big thing to go to the recovery center. That's just a part of what you do as you're getting well.
Thank you all.
Hello.
I really appreciate it.
Hello. Can you hear me? Hi.
Yeah, loud and clear.
Yeah, I just wanted to say too, like right now we have a unique opportunity because a lot of the recovery centers are doing Zoom stuff. So for the clinicians to go on and learn something about that on Zoom is pretty easy right now. But also for our folks that want to access recovery centers, to have them like get used to it with Zoom, it's kind of like a soft, warm handoff, and they can see what it's about, and they can make a good decision about whether they want to use it when they all start opening back up, or whether they want to access that in person. And the other thing I would say about recovery community centers is for like in the hospital setting, the clinicians and doctors and everybody that do the wonderful work there, their time's limited with the folks, so they don't follow them in the community. So the recovery community centers are there forever. So they don't go away. They don't leave the folks, and they're always there, and they can return over and over and over again. So that's just, you know, my thought on that. Thank you.
Thank you, Michael.
Michael.
If I can just share for a brief moment, you know, I'm over in Texas, and we have the recovery coach training, but I was program director at an LMHA, and I was the recovery coach supervisor. And we actually had a formalized process, but people could come to us any kind of way. The formalized process, someone would come into the LMHA, they get assessed and screened, and then from there they would be sent to the recovery coach, the clinician, or the therapist. And what we tried to do was, when people had co-occurring disorders, we would try to get that team, recovery team, together at some point to talk about the progress and things we were working on with the recovery. But we also had people who came in off the street just to the recovery coach, and we would get them to recovery centers, you know, and we would help them in any way we can. We always also had a peer council that was made up of the recoveries, and we had them suggest activities that they wanted to do, and we would develop activities and programs for them to really get, you know, have some fun. So I just want to share that piece.
Thank you, Emmanuel. That's great to hear. Great model to learn about. Like me didn't know what LMHA is, and put in the chat that it's the local mental health authority. So great to hear about.
Hi, my name's Jeremy, the program director for the new center here on Martha's Vineyard. And our team just met with the emergency room people and their SUDS team, and not only introduced ourselves to them, but we talked about, or they talked about, how they would maybe create a code in the, if a client comes in for an SUD or an emergency situation, that they would leave a note that would go to their primary care physician about our center. We gave them information about how to connect to our center, very brief, really simple, and that they would, if somebody came into the emergency room for an alcohol or an SUD, that they would include this as a part of their aftercare paperwork. And it's just a really simple conversation. We made it easy for them. And, you know, we live in a small community, so I bet it's easier for us, but I would, you know, that might be a good suggestion for anybody.
Yeah, that's great to hear, Jeremy, and love that, to hear about that linkage between the ED at Martha's Vineyard and you all. And those are things, like, from a systems perspective, at least on the Massachusetts level, that we could build. I mean, the beauty and curse of having electronic health records is you can build this sort of stuff into it, so that, you know, when patients come in and with a certain type of diagnosis or certain, you know, after an overdose or something, you could have that be a part of the paperwork that goes home with them, or the prompt to the clinician or something like that.
Oh, Ginger, go ahead. Okay, well, my name is Julia, and I work for the Bureau of Substance Addiction Services here in Massachusetts. And together with Danielle O'Brien, we oversee the 26 recovery support centers. We don't call them recovery community centers, but it's the same thing, recovery support centers here. And we're getting ready to open up another 5. So we would have 31. My understanding is that we are the first state in the United States to have so many peer recovery support centers. There's a real belief here in the state of Massachusetts that peer is incredibly important and incredibly valuable, and that our peer centers have an enormous impact on our communities, because they're literally located in communities, and they are run by people who have lived experience in addiction and recovery, and the staff as well. the peer members who live in that community are the ones who actually determine what happens in that particular center. So I'm really excited to hear from the medical community that you are interested and are wanting to figure out how we can work better together. First of all, we need to educate the medical community about who we are and what we do and how we can be most helpful. And then from there, I think, you know, the world is our oyster. This is an area and a community that we have not connected with. The medical community for the addictions world primarily was about prescriptions, was about prescribing. That's what it was all about. And there was an understanding in the recovery community that the medical community really didn't understand who we are and what we go through and what we needed. So this is outside of medication. And so for people in the chat who are asking, recovery support centers are for folks who have decided they want to start their recovery. And they're open 50 hours a week, sometimes weekends, sometimes evenings. They do multiple pathways of recovery, as was mentioned earlier by Wendia. Everything from art happens to meditation to physical education, you know, everything, anything that could really help our mind, body, and spirit to move in a healthy direction. And on occasion, people get trained and educated and get jobs. And so we're open and we're looking forward to folks using us and recovering. And I'm here if anyone wants to. You can chat me or you can call me, and I'm happy to share with you as well as Danielle O'Brien, who's on here.
Thank you, Julia, and thank you, Athena, for putting the list of all the Massachusetts centers in a screenshot if people want to see that or save that. It's in the chat. Great. Well, I know we're coming up on the hour, but we probably have time for one more question or comment if people have it. Or Hazel, I don't know if there's anything that jumped out. I know a lot of great, rich stuff got put in the chat, but
I'll share. Bobby Joe from Kansas City. We've had our Recovery Community Center not quite 3 years, but we are blessed to be able to have an employment specialist that works there full time. We've got a computer lab and help with computer Word, Excel, all those. We have classes for that. We also have a trauma-informed care counselor there that can talk to anybody. We have a resource director there. We have all our people are certified peer specialists that work there. We also have all kinds of different things. They have improv classes. They have yoga. We opened up a gym so people go over to the gym. So it's really, we have budgeting classes and cognitive thinking classes. So all day long from 7:30 in the morning till 4:30 at night, we have different types of programming. And then at night we have our recovery meeting. We're looking forward to opening it all up again to everybody because we've had to regulate our numbers. But we have had great success with our recovery centers here. Just wanted to throw that in there.
Can I talk really quick? I wanted to share what my group does. And I actually work for an opiate treatment center, and we use MAT, and I'm a peer support specialist. So we kind of are like that little bridge that you guys talked about, where I actually work for the opiate treatment center. And my job here is to then connect people who are patients here to the outside community. So we don't use an RCC, but we do use peers. And it's like one of the first in, at least in our state, which is Colorado, and one of the first in, I think, the country as well.
Thank you,
So
Wendy.
I just wanted to share that's a new concept that they're doing too.
Wonderful. Great.
I've been taking so many notes. There's so many great ideas about flyers, about Zoom handoffs, about putting notes in medical records, about just spreading the word, about telling the whole care team, not just the whole part of a care team, but all of them about these approaches. I love this. This is so helpful. There's so many ideas to follow up on. And I think it was either Katie or Hazel who said, if you have other questions or comments, do put them in the chat. We are going through those chats afterwards always and try to upload resources and follow up. So I love all the feedback. Thank you guys. This is absolutely amazing.
Yeah, thank you everyone, the comments in the chat and the comments that people shared. And also a huge thank you to my amazing co-panelists and colleagues and friends who shared today. I think this was an incredibly rich discussion. I look forward to hopefully lots more partnerships and collaborations and brainstorming together after this.
Thank you all. And then the next one we have is coming up in April, right, Bettina?
Correct.
When is that? April the
14th, I think. It's a Friday, mid-April.
Yeah, I think it's the April the 14th. So hopefully see you all back here then for the next one.
It's actually April 16th. I think.
April 16th on Friday. Yeah, great, fantastic.
Invite whoever to join these, right? Bettina?
Absolutely, yes. Everyone is welcome. And we will be discussing sort of like ways in which we track progress in recovery and best ways of thinking about and conceptualizing that. So we'd love your feedback and reaction to the topics we discussed that day.
Great. Thanks, everyone.
Beautiful. Thank you, Sarah. Thanks, everybody.
Yeah, thank you all.
Thank you.